Therapeutic Relationship, Chapter 8. These are the clinical terms you need to recognize, know, and be able to define. So our first objective is really being able to recognize and differentiate a social relationship versus a therapeutic nursing relationship, and our role with our therapeutic nurse and our patient relationship and the qualities we want to have within this relationship. So, our basic of all psychiatric nursing treatment approaches, this is what we want to be able to do, is establish our patient-centered approach. This is what we are going to be doing with our patients. We are focusing in with our patients. We are going to establish a safe, confidential, reliable, and consistent relationship with very clear boundaries. We are going to use our own personality consciously and fully aware. So we use who we are in our relationship with our patient. We establish, at least attempt to establish, relatedness. So for example, you may find that your patient likes dogs and you have a dog. And so you can use that to establish relatedness. I have a dog. I have a golden retriever. I understand you have a blah, 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 blah. And to somehow find and establish relatedness on that. And also part of your use of therapeutic self is to structure your nursing interventions. One of the things that I find quite frequently is that, and most irritating, is when a nurse enters a patient environment multiple times because they did not structure their interventions with the patient, and so they go back and forth, back and forth, back and forth till and don't have all their tasks completed with the patient. Make sure you organize yourself, have your equipment, have those things done, and structure your timing with getting everything completed with your patient that works within the schedule of that patient if it's at all feasible. Becky, 19, has been readmitted to the hospital for an episode of debilitating depression. Becky has the bipolar disorder, depressed type. I was already hospitalized this last month, she says. This is stupid and hopeless. Becky is withdrawn and prefers to lie on her bed. When she must join others in the community room for her first group therapy, she sits with her feet curled under and stares out the window. At times she seems to be holding back tears. At other times she looks angry. Social relationships, initiated for the purpose of friendship, socializing, enjoyment, or accomplishment of a task. Mutual needs are met. Communication to give advice, to give or ask for help. Content of communication superficial. So this is what we do with our friends, okay? We give advice. We give and take in our relationship. We can be selfish. We do it to have fun and enjoy. So this is what we do with our friends and our family. Okay, this is not what a therapeutic relationship is. Clearing boundaries, we'll hold off and go to this slide here first. You are about to initiate your first contact with Becky, which is the most suitable goal in establishing a therapeutic relationship. So is it to establish fun and a sense of fun? Is it to ensure mutual needs are met? To establish clear boundaries while identifying the patient's needs? Or to ensure a two-way communication to give or ask for help? It's supposed to be C, establish clear boundaries while identifying the patient's needs. So necessary behaviors for a nurse. We need to be accountable, focused on those patients' needs, clinical competence, delay judgment, and provide and make sure we are getting supervision. So if you're that charge nurse, you're supervising. But if you are a basic nurse, you're making sure to seek out your supervision. Why do we need that supervision? Because we need guidance. We need to bounce things off. We need to discuss our feelings that we are having. But those things are all necessary. So here's our next objective. So we're going to be talking about the boundaries and the influence of transference and countertransference on boundary blurring. We're going to talk about values and cultures on therapeutic relationships, 3 phases of the nurse-patient relationship, and at least 4 patient behaviors and nurse encounters in a clinical setting. So physical boundaries, the contract, and personal space. Establishing boundaries. So physical boundaries, what's that? What are we talking about? We are talking about the environment. How are you setting, where are you meeting at? Are you going to meet in the office? Are you using a day room? Where should you do an assessment at? Do you do it in front of everybody? Or do you do it in a private space? If the day room is open and no one else is in there and you can close it off to meet privately, maybe in bigger, larger open space is more appropriate. Contract. A contract, when we're talking about this for a meeting or initial visit, is that when you're setting a time to meet and how often you're going to meet, confidentiality or making arrangement for payment, setting things up in advance. Okay, that's a contract that we're referring to. And then personal space. And there's a couple types of space we're referring to. A physical space, getting physically close, touching, no touching, but also emotional space and the roles everybody plays. So blurring boundaries is when a relationship slips into social content. When a nurse's needs are getting met at the expense of a patient's needs. That is when boundaries are being blurred. Okay. So, transference is when these things begin. So when we talk about transference, this is when the patient unconsciously, inappropriately displaces feelings on a nurse that relates to a significant figure in the patient's past, okay? So maybe you remind them of their mother, their father, their sibling, okay? And they get angry at you, irritated at you. You remind me of my mother, or you're cold and you're unfeeling. Blurring the boundaries, okay? You could get a patient who tries to sweet talk you into trying to get something and then all of a sudden turns on you and I hate you. You're just like my mother, because you're saying no to them. And you need to recognize and acknowledge those feelings that the patient's having. And sometimes it's saying, I don't quite understand why you're angry with me right now. Can you explain what's happening? And have them help you realize what's going on, and let's talk about what I'm doing that's who's been so mean to you, or who's been so cold to you in your past when they're saying those feelings to you, so that you can help them recognize what's going on and that it's not necessarily in the present but something from their past that has taken place. Then there's countertransference. That is when you displace feelings onto the patient. Okay, that's something from your past that is triggering the patient. Oh my God, they remind me of my grandparents so much. it triggers and pulls a heartstring. Oh, I want to take this patient home so much. I cannot believe that this child could be so not loved and hurt. I want to just take them home and love them so much into my own little world. And there are common signs of countertransference. One of the biggest one is when a nurse over-identifies with a patient. So okay, so on page 129, there is a table 8.2, that shows some common countertransference reactions. Over-identification is having a special agenda, keeping a patient's secrets, increasing your own self-disclosures about yourself, expressing physical or experiencing physical attractions towards a patient. These are some very common signs of countertransference that a nurse can have or a patient can have. Anger, rescuing, boredom, misuse of honesty, helplessness or hopelessness. I see that helplessness or hopelessness when a patient's not getting better, or a nurse is getting overly happy because a patient is doing better. You should feel happy for a patient, but when you find yourself getting overly happy and excited, then you need to take a look at what's going on with you. Why are you that excited? Because it's not about you. It's about that patient. But you have now taken on more than where you should be. And you're over maybe identifying with this patient. Something's triggered into your own issues that you're having countertransference taking place. And so you need to recognize what is happening. But this is where you're blurring your boundaries with your patient. And going back to transference, there are some countertransference reflections of blurred boundaries on page 127, table 8.1. So take a look at those components and make sure you're familiar with them. Don't be surprised if they don't show up on a test. They give some great self-analysis and some solutions. So values and beliefs and self-awareness. Nurses' values and beliefs, you need to do your own reflection on your culture and your subcultures so that you don't put your own agendas onto your patients. And make sure you derive a range of choices that are within your patient's range of their culture and subculture choices. And choose from a variety of influences and role models for yourself. So these are some things that you need to look at and create your own awareness and your own ranges of choices so that you are able to establish a healthy awareness around your values, your beliefs, so that you can practice healthy with your patients. So you notice that you look forward to talking to Becky because her dark sense of humor reminds you of your best friend in high school. You also begin to make a little cynical jokes, hoping to have a good laugh together. What is the relationship showing early signs of? Accountability, self-reflection, transference, or countertransference? D, countertransference. Now remember, you can use self, but you have to be careful that you don't go too far and use countertransference. So I also want to put on here some thoughts. We won't talk about these, but I want you to think about it because this is where you need to do your self-checking. on where your cultural beliefs are and thoughts. What is your thoughts about someone who has an abortion if they were raped? Or someone who is having an abortion because they just don't want to have a child? Or working with a patient who is a transgender patient and they're on your unit and it's an all men's unit or it's an all women's unit and they have female or male body parts. What's your opinion on working with an AIDS patient who contracted it through IV drug use or was raped and contracted it? Where's your judgments? Where's your thoughts? How are you going to treat this person? Are you going to be able to withhold judgment, attitude? Are you going to be completely non-biased? Are you capable of doing that? Really think about that. So now we're going to Miss Hildegard Pablo and our model of our nursing-patient relationship. Our first one, of course, is our pre-orientation phase. And that pre-orientation phase is all about, before we even get the patient to the unit, you get a call and you're informed on your unit that you're going to be receiving a patient. Now, one of the things that you need to get through really quick in your head is your feelings. You're getting hit with another admission. Here they come. Another one. I've already got 24 patients and you're putting another one on my plate. This is the 5th admission arriving to my unit in this 12-hour shift that I've got, and I don't even know how I'm going to get this all done. You got to deal with those feelings and put them aside because you've got work to do and you need to be receiving this patient with open arms and not let them feel any of your anxiety, animosity about the workload that you're carrying. On top of that, this is also your opportunity to gather any lab work about this patient, any of their diagnosis, and do a little bit of research on this information about the disease that this patient may be carrying, because you may not know some information about it. It may be new information of a disorder that you don't know, that you can do a little Google search and look up this information. That's what pre-orientation phase is all about. I'm going to backtrack again. In orientation phase, we are also gathering information and assessing and getting our assessment data from our patient during this phase. We're going to gather further data in our working phase, but we're going to be working with our patient and promoting skills, self-esteem, and use of language. And we are going to be honest in this working phase. We are going to be talking, providing medication education, evaluating our progress with our patient. So we are going to be talking about the disorder with this patient. We are going to be really working on making sure this person's learning as much as possible during this working phase, and giving them, so this relationship is really established, really progressing forward, so that we can get as much work in as possible, so that we can go and continue to facilitate those behavioral changes, overcome those resisting behaviors, evaluate and the problems and goals and redefine them. So as goals get achieved, we create new goals and set new ones, redefine them as we go along, promote and practice expressions of alternative adapting behaviors. So we get into this termination phase where we're going to then summarize goals and objectives, discuss ways for the patient to incorporate new goals and strategies that they have learned, and review situations of the relationship and exchange memories. Okay, So in this relationship, at the end, this is where we're saying goodbye, but the way we're saying goodbye is to say, look at where you came in at. This is how you started. Look at where you're at now. And a lot of times the patients who come in screaming and kicking and yelling are the ones that have the hardest time going out the door. And they're the most ones at fear. And when we were talking about the fact of at levels of care, when the patients are changing levels of care, being at great risk for suicide, this is when we're talking about them going home and all the stuff they've learned now. We're sending them home at a different level of care, and they're needing to practice these things. And it's scary because they're not sure they can do this, and they feel like they're doing this on their own, even though we've got all these people set up and in the outside to do this with. They have to go back and reestablish these phases of relationships and go back to the pre-orientation and orientation working phase again. But they've done this once, and now we have to get them to understand that they can do this again and be successful, because look at what they've done. Look at all these things they've done and review the situation of these relationships. And so this is what we're doing, and look how far they've come. So now we're going to go through the roles of empathy, genuineness, positive regard, the attitudes and the 4 actions reflected of a nurse with positive regard. Understand the attentive behaviors, the body language, eye contact, vocal qualities, and verbal tracking. So, factors that help a nurse-patient relationship. Consistency. I always tell my students, my coworkers, we live in a fishbowl, and you need to understand this. Our patients are always watching us. They always see how you interact with your coworkers and with your other patients. Now, in a med-surg facility, patients are always in their rooms. In a psychiatric facility, patients aren't in their rooms. They are all about the unit. We hardly ever have our patients in their rooms. And this is for safety purposes, okay? They're out and about in the day room and the hallways, so they always see you. So, one of the things that happens when we're talking with our patients and they're seeing you all about and interacting is, how do you talk to other people? How do you interact? How do you greet? How do you smile? How do you help other people? So, when you're meeting with a person and you're sitting down, you're going to be consistent in your conversation, and consistent. When I say I'm going to meet with you, I'm going to meet with you. Pacing. How fast do we talk? Listening. Am I listening to this person? Am I hearing what they're saying? What is my initial impressions? What initial impression am I giving my patient? Promoting patient comfort and balancing control. There's a difference between letting a patient scream all over the unit and allowing the patient to have comfort at the same time. There is a difference, because I can't have patients screaming all over and being able to let people be comfortable. There's got to be a balance, and how do you provide that balance and keeping someone comfortable and allowing them to express themselves and be comfortable, but actually allow control at the same time. How factors that are important. trust, and active participation. Active participation. They've got to trust you. I've got to trust my patient. They've got to actively participate. They've got to. If they don't engage, then what's the purpose of them seeking treatment? If they don't have a buy-in, they're not going to get better. So we have to have that. We have to establish trust. So how do we show genuineness? Genuineness comes from being open, honest, and authentic. It's spontaneous. We listen. We communicate clearly. Empathy, we've talked about this a little bit already, but I'm just going to re-emphasize this. Empathy is understanding the world from the patient's perspective. Sympathy is when we feel pity and sorrow for the other person. Empathy is a technique. It's an attitude. It's not a technique, but it's an attitude. It conveys respect, acceptance, and validation. Positive regard implies somebody is worthy of being cared about. It's respect. An attitude, a willingness to work with a patient. It's paying attention. Attending. It's paying attention. It's being present. You actually hear what the person is saying. You don't have to have them repeat because you're actually there in the moment instead of being distracted by the phone or by the noise or picking up something. You stay in the moment with the patient. You suspend being your value, judging anything. You listen. You don't jump to conclusions. You help the patient develop resources, come up with ideas. If you don't know what they are, let the patient know. Let me go do a little research and come back to you in 30 minutes or an hour and let me see what I can find. Why I do that, why don't you research on your phone? Because sometimes your patients need to do some of the work themselves. After your first conversation, Becky withdraws from you, again, before you even really begun. Which statement will contribute most to establishing Becky's trust? Weren't you complying with your medication regime? It must be discouraging to be readmitted to the hospital so soon. Everyone with bipolar disorder ends up in the hospital occasionally. You must take your drugs as prescribed or you will be re-hospitalized. If you said B, it must be discouraging to be readmitted to the hospital so soon, you're correct. So part of what you want to do is state the obvious and acknowledge the person's feelings. Okay? State the obvious, acknowledge the person's feelings. It must be discouraging to be readmitted to the hospital so soon. And that's what she was talking about earlier, is she was upset. She was having to be readmitted in the hospital. She might as well give up. Becky tells you, I have something secret to tell you, but you can't tell anyone else. The nurse agrees. What is this likely consequence of the nurse's actions? Healthy feelings of sympathy by the nurse towards the client, blurred boundaries in the nurse's-client relationship, improved rapport between the nurse and the client, enhanced trust between the client and the nurse. I should say the nurse and the client. You should have picked B. Those are blurring of those boundaries. Otherwise, we're in trouble. The nurse spends extra time with the client who has personality features similar to the nurse's estranged spouse. Which aspect of countertransference is most likely to result? Over-involvement, misuse of honesty, indifference, or rescue? If you said A, over-involvement, you're on target. As Becky is preparing for discharge, she presents you with a handmade card of appreciation for the care you provided. Should you accept the card? Yes, A is